Hola, muy buenas noches. Bienvenidos a nuestra sesión mensual de la Asociación Mexicana de Endoscopia Gastrointestinal. Bienvenidos y le concedo la palabra al doctor Ángel Andrés Reyes Dorantes, presidente de nuestra asociación.
Muchas gracias, doctora Zamorano. Estimada audiencia que nos sigue por internet, esperemos que esta sección sea muy ilustrativa, de mucha enseñanza para todos, preparado con mucho entusiasmo. Quiero presentarles a nuestro coordinador, el doctor Guido Grajales, que nos hará la presentación de nuestros expertos nacionales y de nuestro profesor invitado.
Muchas gracias, Ángel. Gracias, Yolanda. Buenas noches, sean todos ustedes bienvenidos a la cuarta sesión mensual de nuestra asociación. Y sí, efectivamente, con un tema muy importante para todos los endoscopistas, qué hacer con aquel paciente que tiene hemorragia de intestino delgado. Y para ello, contamos con invitados de lujo. Esperemos que esta sesión sea de su agrado y que se consiga el aprendizaje que todos buscamos. Contamos con un profesor internacional de renombre, es el doctor Jonathan Leighton. El doctor Leighton fue jefe de la división de Gastroenterología de la clínica Mayo en Scottsdale, Arizona, y actualmente es el subjefe de la división de medicina de este hospital. Agradecemos al doctor Leighton su participación en esta sesión. Y contamos con nuestros dos invitados nacionales, la doctora Clara Luz Martínez García, expresidenta de la AMEG y jefa de la unidad de endoscopía del Hospital San Angelín Universidad. Asimismo, contamos con la participación del doctor Gerardo Blanco Velasco. Él es médico adscrito al Departamento de Endoscopía del Hospital de Especialidades del Centro Médico Nacional Siglo XXI. Muchas gracias a ambos por participar con nosotros. Y comenzaremos con la charla del doctor Leighton, que se titula Videocápsula endoscópica en hemorragia de intestino delgado. Continúa siendo el estándar de diagnóstico. Muchas gracias, doctor Leighton, y comencemos con su conferencia.
Hello, my name is Jonathan Leighton, and I am a professor of medicine at the Mayo Clinic, and I would like to take this opportunity to thank the Mexican Association for Gastrointestinal Endoscopy for inviting me to give this lecture. The name of the lecture is Videocapsula Endoscopy in Small Bowel Bleeding. Is it still the gold standard in diagnosis? And I think as you listen to my lecture, you will agree that that is still the case. To give a little background, small bowel bleeding accounts for 5 to 10% of all gastrointestinal bleeding. Capsule endoscopy, device-assisted enteroscopy, and multi-phase CT scanning identifies small bowel sources for bleeding in about 40 to 75% of cases of obscure GI bleeding. Because of that, most cases of obscure GI bleeding can now be termed suspected small bowel bleeding, and as you'll see in a moment, the guidelines were changed because of that. Obscure GI bleeding should be reserved for cases where no source is identified after a small bowel evaluation. So let's start with a case. This is an 84-year-old female with a 2-year history of iron deficiency anemia and guaiac-positive stools. Her hemoglobins range from 8 to 11, requiring transfusions every other week, and therefore it really negatively impacted her quality of life. Upper endoscopy, colonoscopy, push enteroscopy, small bowel follow-through, CAT scans, bleeding scans, and angiograms were negative. And so the question is, what test would you do next? And in this case, we did perform capsule endoscopy. And if you look very closely at this image here, you'll see very quickly that a lesion popped up, and it went by so quickly you probably couldn't see it, and that's because it was in only one frame. We weren't sure whether it was a significant lesion or not, but it was in the mid-small bowel. It was seen on only one frame, so we proceeded with an antegrade or oral double balloon enteroscopy, and you can see here we went down 400 centimeters and started coming back. And as we pulled back in the mid-small bowel, there was this polypoid lesion that turned out to be a polypoid hemangioma. So you can see the power of capsule endoscopy in helping us determine the source of small bowel bleeding. So as I said, the original the definition of obscure gastrointestinal bleeding was bleeding of unknown origin that persists or recurs. And it could be overt if there's visible blood, or it can be occult if it is only fecal occult blood test or iron deficiency anemia. In addition, it had to have a normal upper and lower endoscopy plus second look endoscopy when appropriate. But since then, because of improved detection and treatment of small bowel lesions due to advances in both endoscopy and radiology, in the latest American College of Gastroenterology guideline, we felt that the definition should be changed and was recommended that you consider a small bowel bleeding source in patients after a normal upper and lower endoscopic evaluation. And therefore, patients should be classified as having potential small bowel bleeding prior to capsule endoscopy and other imaging techniques. And then the term obscure GI bleeding should be reserved for patients not found to have a source after new small bowel imaging techniques have taken place. Let's move on to how small bowel bleeding commonly presents. And it can be, in most cases, chronic and intermittent, but as I mentioned earlier, it can be overt with hematochezia or melena, or occult with iron deficiency anemia. And it usually is located between the ampulla of Otter and the ileocecal valve. The differential diagnosis: vascular lesions, anti-inflammatory drugs, Crohn's disease, primary tumors and metastases, and then less commonly radiation and portal hypertension. Extraluminal sources, not coming from the GI tract, would include hemosuccus pancreaticus, hemobilia, and aortoenteric fistulas. Now, I thought this was an interesting article from 2018, which showed that the presence of melena in suspected small bowel bleeding does predict a proximal small bowel source. And this was a retrospective cohort of 288 patients, and there were melena in 37%. And of those, 56% had a proximal source when there was melena, but without melena, it dropped to 34.8%. And when they did multivariable analysis, the presence of melena doubled the odds of finding a bleeding site within the proximal small bowel. So it's good to know this in terms of working up patients with small bowel bleeding. I mentioned second look endoscopy, and so the next issue is, when should repeat standard endoscopy be performed prior to starting a small bowel evaluation with capsule endoscopy? And I think this requires a careful selection of patients to ensure a cost-effective approach. For example, in patients who present with iron deficiency anemia, other causes such as celiac disease, hematologic and/or gynecologic etiologies should be considered first. It's also important to remember that up to 25% of lesions can be missed on the initial upper endoscopy or colonoscopy. Therefore, if the previous exam, upper endoscopy or colonoscopy, was limited due to bleeding, or a recent high-quality exam was not performed, then we do recommend a second look endoscopy prior to embarking on a small bowel evaluation. Remember, when you're going to repeat the upper GI evaluation, if high-quality exams have already been completed, then second look endoscopy is likely not to be cost-effective and should be avoided. When you do it, consider push enteroscopy to increase the depth of the exam and to closely examine the duodenum and proximal jejunum. Remember, when repeating a colon evaluation, always intubate the terminal ileum to look for small bowel causes. And once second look endoscopy has been completed and high quality, then a formal small bowel evaluation should be pursued, typically starting with capsule endoscopy. Now we know the techniques that are currently available for evaluating the small bowel. You do have capsule, you have deep enteroscopy, and you have cross-sectional imaging, and we'll review all of those today. Capsule endoscopy, there's basically two main types of capsule endoscopes. Number one, we have the wireless capsules that transmit images to a receiver, which you can get with the PillCam, Olympus, and Miracam. And then there are wire-free capsules that store images in the device itself. And here you have that with the CapsoCam. At this point, based on studies that we have, we don't appear to see any significant difference in head-to-head comparison trials in terms of better performance. And again, if we just use a case, this is a 70-year-old male with ischemic cardiomyopathy and LVAD placement on warfarin and aspirin, who presented with melena and hemoglobins ranging as high as 11 to 7.5. Again, endoscopy was negative. Colonoscopy did show dark clots in the cecum, but the ileum was normal. We then proceeded with capsule endoscopy as the first screening test. And when we did the capsule, we didn't think there was going to be blood in the small bowel, but lo and behold, we did find blood in the small bowel, and it was about 30% of small bowel transit time. We did deep enteroscopy and found a bleeding vascular lesion that was treated. So in addition to overt bleeding like that, what about the diagnostic yield of capsule for iron deficiency anemia? And this was a systematic review of 24 studies involving close to 2,000 patients. And you can see here that the pooled diagnostic yield was 47%, although there was statistically significant heterogeneity in the populations. But if you looked at the pooled diagnostic yield in studies that focused only on iron deficiency anemia, the overall yield was 66.6%. So even for patients with iron deficiency anemia, capsule endoscopy seems to be an ideal first test. Now, are there ways that we can improve the yield of capsule? Well, there are. First of all, as I mentioned, and to remind you, the two main types of capsule endoscopes, you have the wireless capsules that transmit images to a receiver, and then you have the wire-free capsules that store images in the device itself. In terms of the diagnostic yield, we know it ranges anywhere from 59 to 67%. It's important to realize that the yield is greatest when performed as soon as possible after bleeding, and preferably performing it on anticoagulation so that the bleeding will continue. In hospitalized patients, early deployment within 24 to 72 hours of admission has shown to increase the diagnostic yield. And that other characteristics that may increase yield include overt bleeding, anticoagulant use, inpatient status, male, older age, liver and renal comorbidities. And this just shows from this early study that the diagnostic yield of capsule endoscopy does deteriorate over time. Now, what about decreased capsule yields? What is that associated with? And here you can see poor bowel preps will decrease the yield, as will incomplete studies, which can occur in 20 to 30% of patients. And the risk factors for incomplete studies, meaning that the capsule doesn't reach the colon, is hospitalization, small bowel surgery, narcotic use, delayed gastric transit, and decreased physical activity. And solutions are, if you have a hospitalized patient, for example, make sure that you increase ambulation, or if you have someone with delayed gastric emptying, endoscopic placement. As far as bowel preparations, I don't think we know what is the ideal bowel prep. In addition to all of this, I remind my colleagues to avoid gastric and small bowel biopsies prior to capsule endoscopy because it can lead to false positive findings. Now, talking about bowel preparation for capsule, as I said, the studies are controversial and conflicting. And multiple preps have been recommended, from overnight fasting only to clear liquid diets the day before, purgatives, anti-foaming agents, and prokinetics. I will say that here we do use a 2-liter PEG with simethicone, 40 milligrams, and we believe that that may lead to the best diagnostic yield and visualization based on previous meta-analyses. But I also have to say that the recent meta-analysis contradicts previous ones and suggests that bowel preps don't improve the diagnostic yield. So you'll find this to be very institutionally specific on what they do. One of the risks is retention of the capsule, and there are other adverse events. So what can you do to minimize those issues? Capsule retention is defined as the presence of the capsule within the small bowel for over 2 weeks, or requiring an intervention to facilitate passage or retrieval. In most cases with capsule retention, patients are asymptomatic and bowel obstruction is rare. The overall retention rate we think is under 2%, but rates may go up as high as 13% in patients with Crohn's disease, particularly established Crohn's disease. Risk factors for retention include strictures, NSAID enteropathy, tumors, diverticuli, hernias, and a history of GI obstruction. So it's also important that patients understand this risk, as well as the concept of therapeutic complication, meaning that sometimes I do have patients who present with abdominal pain. We suspect a small bowel stricture, but can't identify it, and we'll actually use the capsule to identify that, and that's what we call a therapeutic complication. But with all of our patients who undergo capsule endoscopy, we do get informed consent around that. And so in high-risk patients, it's important to obtain informed consent and alert surgical colleagues in advance if you're going to use the capsule. And in high-risk patients, if you are looking to avoid capsule retention, then you can consider the use of a patency capsule and/or cross-sectional imaging to help determine patency of the small bowel. Now, what are the relative contraindications to capsule endoscopy? Implantable cardiac devices are one, but I can tell you that based on the literature and some of our own studies, the risk appears to be extremely low. You still may want to monitor patients using wireless telemetry, particularly if they have dependent pacemakers. And it's important to remember that one of the systems that doesn't use wireless technology does not pose any risk in these situations. Pregnancy is another relative contraindication, and swallowing disorders are also considered a contraindication. Aspiration can occur, but it's rare. If there is significant problems with swallowing, then we recommend performing endoscopic placement. And then it's just important to remember that if a patient requires an MRI immediately after a capsule, then we recommend documenting capsule passage before the MRI is performed. Let's move on now to deep enteroscopy that we call tube or balloon-assisted enteroscopy. You have double balloon, single balloon, and the spiral over-tube enteroscope. And the one advantage to this technique is that it does allow for forceps channel biopsies and therapy. And for example, what's nice here is you can see that in this lesion that we identified in the mid-small bowel, you can see that there is an adherent clot. And with most of these, we first inject with epinephrine to prevent any acute bleeding. And then we will use APC or argon plasma coagulation to coagulate. And then in most cases, we'll then tattoo the lesion in case we have to go back and treat it again. And this is the advantage to deep enteroscopy over capsule endoscopy, is the ability to perform therapy. Now, what about the degree of concordance between double balloon and capsule endoscopy? And this was a nice study that was prospective, looking at 193 patients. And you can see that the overall kappa result was good at 46, and maximum concordance was for vascular and inflammatory lesions, less concordance with polyps. Blood on capsule was seen in 34 cases, with 12 negative deep enteroscopy. And the conclusions from this study are that capsule and double balloon enteroscopy have good agreement for vascular and inflammatory lesions, but not so much for polyps and neoplasia. Double balloon complements capsule, again, particularly in patients with neoplasia or polyps when they're missed on capsule endoscopy. And deep enteroscopy clarified the origin of bleeding in 2 out of 3 patients where the capsule showed only blood. So while the capsule is still a good first test, you can see how deep enteroscopy can be complementary. And in this meta-analysis, comparing the two, again, the pooled diagnostic yield was similar, 62 versus 56%. However, and this is important, the diagnostic yield of deep enteroscopy significantly increased if performed after a positive capsule. And the deep enteroscopy yield fell to 27.5% if performed after a negative capsule. So the capsule is very useful for predicting improved diagnostic yield with deep enteroscopy. So capsule and double balloon have good agreement for vascular and inflammatory lesions. I think that the double balloon complements capsule endoscopy, particularly in patients with neoplasia or polyp. And again, it clarifies the origin of bleeding in many patients where you only see blood. Based on the American College of Gastroenterology guideline, capsule should be the first-line procedure after second-look endoscopy to increase the diagnostic yield. So again, this most recent guideline again affirmed that capsule should be the first-line procedure. If proximal lesions are suspected, it's also recommended that you include push enteroscopy as part of second-look endoscopy. In addition, capsule should be performed before deep enteroscopy to increase the diagnostic yield, as I showed in that meta-analysis. And a negative capsule is associated with a lower risk of rebleeding overall. And we think the capsule is an excellent screening tool prior to deep enteroscopy, and there is evidence that supports that. In capsule transit times we think are useful, and we use the antegrade or oral approach for lesions with a time index value less than 0.6 of the pylorus to cecal time. And then we use the retrograde or rectal approach for more distal lesions. Also, this approach increases both the diagnostic and therapeutic yield of deep enteroscopy. An antegrade approach has been shown to have a greater diagnostic and therapeutic yield, likely due to a higher prevalence of vascular lesions in the proximal small bowel. As I mentioned earlier, a negative capsule allows for the avoidance of deep enteroscopy in patients with a low pretest probability for small bowel findings. And then similar to capsule, deep enteroscopy should be performed as close to the bleeding episode as feasible if you're going to improve the diagnostic yield. Let's move on a little bit to radiology. So when should radiologic imaging be considered in small bowel bleeding? And I like to think that indications for radiologic imaging include when the capsule is negative or contraindicated, when there's brisk bleeding and hemodynamic instability, or when suspected Crohn's disease exists or mass lesions. And the current options are multi-phase CT scans, which is what we mainly use, MR enterography, bleeding scans, mesenteric angiograms, and Meckel scans. And we'll mostly focus on the multiphasic CT. We think that the multiphasic CT scan is excellent for acute and chronic small bowel bleeding, and it complements capsule. There are 3 phases a bolus-triggered arterial phase, an enteric phase, and then a delayed phase. The pre-IV contrast imaging is followed by a rapid bolus of IV contrast, followed by arterial and venous phase imaging. A CT angiogram is preferred for active bleeding, and if positive, can direct mesenteric angiography and also embolization. And then, as I said, CT enterography with oral neutral contrast is best for chronic bleeding and has a fairly good sensitivity. There are newer techniques that use dual energy CT that reduces radiation dose as well. And this just gives you an idea. This is the pre-contrast arterial and venous phase, and this is an active jejunal bleed where you can see increased bleeding through the three different phases, which tells you that there is, in fact, a bleeding source. And this multi-phase CT angio without oral contrast really should be considered, especially when endoscopy is not diagnostic. Even in this case, though, capsule is superior to multi-phase CT for disorders. And you can see in this meta-analysis of 10 studies that the pooled overall yield was higher with capsule than CT, 49.7 versus 29.7%. And the 7 studies of capsule versus multi-phase CT pooled diagnostic yield being greater with capsule was mainly due to higher detection of vascular lesions with the capsule. There really was no difference in inflammatory or mass lesions. But again, the capsule does have a higher diagnostic yield, and this suggests that capsule is still the first test of choice in the setting of suspected small bowel bleeding. So what's a reasonable approach? And this is my recommendations based on the literature. For most small bowel bleeding patients, capsule should be performed before deep enteroscopy for the reasons that I mentioned. I will say in a subset of patients where there is active bleeding and they're hemodynamically stable, it would be very reasonable to proceed with deep enteroscopy in that case, assuming there's a high likelihood of small bowel bleeding. If no source is identified with capsule or deep enteroscopy, then that's where you would consider CT angiography. And then for obstructive symptoms or suspicion of Crohn's disease, then I would recommend CT enterography or MR enterography. Moving on just a little bit to epidemiology and natural history of small bowel bleeding, we do find that the type of lesion correlates with age, but not gender or ethnicity. So angioectasia are the most common lesions, particularly in the elderly. And risk factors for angioectasia include advancing age, aortic stenosis, chronic renal failure, and LVADs. Recurrent bleeding from angioectasia correlates with the number of lesions, advanced age, presence of comorbid conditions, and anticoagulant therapy. The challenge for all of us is that when we find a non-bleeding angioectasia, we don't really know if that's the cause of bleeding. And uncertainty, therefore, exists whether angioectasia detection and ablation affects long-term outcomes, because most of the angioectasias that we detect are not actively bleeding. And the bleeding source, although is found in up to 80%, remember that rebleeding occurs in as many as 30 to 45% of our patients, and that continues to be a problem. And you can see from this study, long-term outcome is still not great for patients undergoing capsule and deep enteroscopy for vascular lesions. And in this prospective multi-center trial, more than 70% had a positive deep enteroscopy after a positive capsule for a vascular lesion, yet 35% still had rebleeding during 1 year of follow-up. So I think there's an opportunity for all of us to improve our diagnostic and therapeutic capabilities in patients bleeding from small bowel vascular lesions. What about additional tools that are available in refractory small bowel bleeding? Again, as I said, we know rebleeding occurs in up to 45% of patients after 2 to 3 years. So don't forget about Meckel's and doing a Meckel scan, particularly in young men. Also, consider a trial of oral or intravenous iron replacement. If no response to conservative management, then you may need to repeat endoscopic and imaging evaluation, but preferably do it on anticoagulation. For more serious bleeding, again, consider provocative angiography, and always consider Hyde syndrome, and if present, perform an aortic valve replacement. Remember that surgery is considered a last resort in most cases. When should pharmacologic therapy be considered for small bowel bleeding? I think there's limited data and role in this area, but the ideal candidate would be somebody who's got refractory bleeding, multiple comorbidities, contraindications to endoscopy once a serious lesion such as tumor has been excluded. And in that case, you can consider medical therapy. Hormonal therapy at this point is not thought, based on previous studies, to have any proven benefit. But somatostatin analogs appear to decrease bleeding rates and transfusion requirements with angioectasia. And then also thalidomide also appears to be effective as an anti-angiogenic, and you can consider one of those two drugs. So I've given you here a nice workflow for how to approach small bowel bleeding. If they're hemodynamically stable, and if the patient is anticoagulated, consider keeping the patient on therapeutic anticoagulation. Rule out celiac disease, hematologic, and gynecological pathologies. Remember to repeat upper and lower endoscopy if not previously performed. If that's negative, then you go to videocapsula endoscopy. And if you find a lesion, then based on the transit time, pursue antegrade or retrograde deep enteroscopy. If the capsule is negative or the capsule is contraindicated, then you proceed with multi-phase CT enterography, and then go on as indicated, as you can see here. Remember, if they're hemodynamically unstable, then you may consider the multi-phase CT angiogram and the mesenteric angiogram with embolization. So in summary, the majority of cases of previously termed obscure GI bleeding can now be classified as having small bowel bleeding. Capsule endoscopy is indeed the first test of choice in most cases after a thorough negative upper endoscopy and colonoscopy. Endoscopic techniques such as capsule, deep enteroscopy, as well as cross-sectional imaging techniques can help localize small bowel bleeding sources and really should be considered complementary. Remember that the type of bleeding and the timing of the procedures is important to increase the diagnostic yield, and you should do those procedures as close to the bleeding event as possible. And then remember that the long-term outcomes of vascular lesions is still not great, and that needs to be improved. So thank you for listening, and I look forward to taking any questions. Thank you.
Good night, Dr. Leighton. Thank you for your excellent conference. We have some questions for you. A la audiencia, muy buenas noches. Estamos aquí el doctor Gerardo Blanco y una servidora para iniciar una serie de preguntas y sacarle mucho provecho a esta interesante conferencia que nos termina de dar el doctor Leighton. Les pediría que, si son tan amables, de enviarnos sus preguntas. Y the first question, Dr. Leighton.
Hello, Dr. Leighton. The first question is what we should do with Saurine's P1 lesions like red spots and erosions?
That's a very good question. Normally, if I see red spots and they are not bleeding, I don't worry about them unless they are larger and have more of a pattern consistent with an angioectasia. We do see a lot of red spots in the small bowel in patients that don't have bleeding. So I think most of us think that you don't have to worry about them. With erosions, then that raises the possibility of either NSAID enteropathy related if the patient has a history of taking anti-inflammatory drugs. Otherwise, one can also think about Crohn's disease, although that is based on the chronicity of the lesions and if they are persistent for a long time. But many of those patients with small erosions in the small bowel don't necessarily require treatment unless there is ongoing bleeding.
Thank you, Dr. Leighton. We have to repeat a negative capsule.
That's also a very good question. Remember, in most cases, a negative capsule is a good indicator that deep enteroscopy will also be negative. And if you're worried about vascular lesions, capsule endoscopy is very good for picking them up. So if you don't see any vascular lesions on the capsule, then I don't think you have to repeat it. However, in someone who has persistent bleeding or persistent symptoms, capsule endoscopy can occasionally miss polyps or single mass lesions. And so if a patient continues to bleed, we will either repeat the capsule or do some type of cross-sectional imaging, such as CT enterography.
In a patient with melena and negative upper endoscopy, what do you think of doing capsule endoscopy before colonoscopy?
Well, that's a very good question. I think I showed a recent study in 2018 that suggested melena is a good sign that there is more proximal small bowel bleeding. Having said that, because of the fact that colon cancer is common and occasionally right-sided colon lesions can cause melena, I think most patients still deserve a colonoscopy, although I don't think there's anything wrong with doing a capsule endoscopy first, but in most cases, I think most patients are going to get a colonoscopy first.
Okay, Dr. Leighton, if the capsule is complete and negative, but the gastrointestinal bleeding persists, what do we do?
Yeah, and this is the area that needs to get studied more because we don't have a lot of evidence-based studies to tell us exactly what the next step is. What we tend to do is we will get usually a multi-phase CAT scan that allows us to what we call a triple phase, and it allows us to look for a bleeding lesion. That is very helpful often, but if it's not, then we will go to deep enteroscopy after that.
In which case you recommend to do an enteroscopy if we have a retained capsule?
Yeah, ideally, rather than when we initially started doing capsule endoscopy, we sent all of these patients to surgery. But now with deep enteroscopy, many times we will use deep enteroscopy to locate and remove the capsule endoscope. So I think if we can avoid surgery, that's good. Now, there are some patients, obviously, where the capsule shows either a very tight stricture or a mass lesion, and then in those cases it's worth doing surgery. But for our patients with Crohn's disease, if they aren't symptomatic from the stricture, then using deep enteroscopy and retrieving the capsule and avoiding surgery oftentimes is better.
Dr. Leighton, we must always prepare the small bowel for capsule study.
We do, as I mentioned in my talk, there are some meta-analyses that suggest that a preparation is better for the quality of the prep and also for the diagnostic yield. But then most recently there was another meta-analysis that suggested it did not improve the diagnostic yield. So I think we don't know for sure, but we prefer to give a 2-liter prep with simethicone prior to the procedure. But there are many other gastroenterologists around the world that don't do it. It's about 50-50, half and half. But we like to do it.
Thank you. If a tumor is the cause of the bleeding, which is the next step? CT, enteroscopy, or surgery?
If we identify a tumor, we'll usually do then CT enterography to characterize it, and then almost always we will then proceed with surgery. If there's evidence to suggest that it might be a lymphoma, then we may do deep enteroscopy and get biopsies and then send to the oncologist. But otherwise, for most tumors, we'll do a CAT scan and then surgery.
In a case of a negative enteroscopy with a positive capsule, when should we do another enteroscopy with other approach?
Yeah, so another good question. I think if the capsule endoscope shows a lesion, and if it's in the first 60% of the small bowel transit, we will start with an antegrade or oral deep enteroscopy. But if that is negative, then we will go right to a retrograde or rectal deep enteroscopy. And when we do the first exam, we tattoo the most distal point, and then on the second exam, we try to get to that tattoo so that we know that we have done total enteroscopy. We don't do it on the same day, but we will do it a few days later depending on the situation. But I think in that case where the capsule endoscope is positive and the first deep enteroscopy is negative, then we will do it from the opposite end, and I think that's important.
In which case you recommend and when to call a surgeon?
With all of our techniques now, whereas we used to have to call a surgeon often, we rarely have to do that now. There are two situations where I think we would call a surgeon. One is in someone who continues to bleed. We know it's in the small bowel. We can't find it. And in that case, we may do provocative angiography where we give them heparin, or we will do intraoperative endoscopy with a surgeon. The other situation where we'll often work with a surgeon is in somebody with Peutz-Jeghers syndrome who has multiple large polyps on capsule endoscopy, and then we'll do a combined procedure where we will try to resect smaller lesions and then very large lesions. The surgeon will help us. So those are the two situations where we might call a surgeon.
And Dr. Leighton, what I have to do in incomplete capsule?
if we come across an incomplete capsule, I think you still believe, and you haven't seen the entire small bowel, there are a couple of things that we do. If they're patients on narcotics or they have diabetes, then we, on the next capsule, will try to place it endoscopically. If the incomplete capsule happened while they were in the hospital, there is a higher risk of incomplete capsule endoscopes in hospitalized patients. So then we'll try to do it as an outpatient because we have a higher likelihood of completing it. And then there's always that occasional case where they have no risk factors for capsule retention. And in that case, we will just do it again and give it to them just in the usual way, swallowing with water. But I think if they have delayed small bowel transit, then I think you have to place it endoscopically. Or if they have delayed emptying from the stomach, then you have to place it endoscopically.
Another question, which is the overall percentage of rebleeding and what we have to do?
I'm sorry, what was that?
Which is the overall percentage of rebleeding and how we study these patients?
So this, I think, is the biggest challenge for those of us that focus on small bowel bleeding, because right now, in patients, particularly with vascular lesions, the rebleeding rate can be as high as 50%. And many times we see vascular lesions on capsule endoscopy and they're not bleeding. So we don't always know that that is the problem. But in many patients with angioectasia, the studies would suggest that it takes multiple sessions, at least 2 or 3, to fully stop the bleeding. So I think when we identify patients with vascular lesions, we have to, as gastroenterologists, realize that we may have to go back several times to continue to ablate some of these vascular lesions to fully stop the bleeding. But I think one of the frustrating issues is that the rebleeding rate is quite high, and we need more studies to understand why the clinical outcomes in these patients aren't as good as we would like.
You already told us about the angiectasias, but what we should do if we only find a small angiectasia and it's the unique lesion?
Well, I think if it's in someone who has that recurrent bleeding or iron deficiency anemia, if I understand the question, then we will go with deep enteroscopy and ablate that, usually with argon plasma coagulation.
Okay. Thank you, Dr. Leighton. Which is the ideal time for the study of capsule?
What's the ideal what?
Which is the ideal time for the study of capsule?
The ideal time?
Yes. In the days.
Well, you know, usually early in the morning, and you know, as soon after a bleeding episode as you can do it. But we usually we have the patient come at 7 o'clock a.m., 7 in the morning, to do the capsule, and then they usually return it in the evening or the next morning.
What do you think about transoperative enteroscopy?
About what?
An enteroscopy in a surgery, while a surgery.
Yeah, well, we have occasionally, we do it mainly in patients with Peutz-Jeghers, because then you can do a combined procedure where we remove as many polyps as we can endoscopically, and then for very large lesions, we may have the surgeon do an enterotomy, open up the small bowel and remove large lesions. But we're doing that less and less these days. But I think that can be very helpful. And occasionally we'll do it for someone who has persistent bleeding that requires transfusions, and we can't identify the bleeding source endoscopically.
Well, Dr. Leighton, we run out of time. It was a great pleasure to have you as our international professor. I hope we can continue having mutual collaborations with you and your hospital. This has been a great opportunity to see you again and to have all your knowledge for our associates here in Mexico. Agradecemos. I don't know if you would like to say something to our Mexican audience.
Yes, well, first of all, I have been to Mexico and Mexico City many times, and I love to visit, and it has been very good to see you again, and I want to thank everybody for attending tonight, and it was a great honor to be invited to do this, so thank you.
Thank you again. Y agradecemos a nuestros invitados nacionales. Creemos que fue una sesión muy provechosa para todos. Creo que todos aprendimos. Gracias a la doctora Clara Luz, gracias Gerardo por la participación con nosotros. La próxima está planeada para el 11 de abril. Tenemos un profesor internacional de España, es el doctor Enrique Pérez Cuadrado, con un tema bastante innovador, inteligencia artificial en endoscopía, pero bueno, esperamos que se conecten. Yo les agradezco su participación. Me despido de ustedes y cedo la palabra a Yoli Zamorano, nuestra secretaria, y al doctor Reyes Dorantes, nuestro presidente. Que tengan buenas noches.
Muchas gracias, Guido.
Buenas noches,
Buenas
entonces les vamos a dar los anuncios. El curso en línea de asistente en endoscopía del aparato digestivo se inicia el día 9 de marzo. Por favor, solamente quedan 5 lugares para que se inscriban, por favor. El EndoCollege está disponible en línea y el próximo programa líder es diagnóstico avanzado de lesiones premalignas de tubo digestivo. Tiene un valor curricular avalado por el Consejo Mexicano de Gastroenterología de 12 puntos y quedan pocos lugares. Se dará inicio a este curso el 14 y 15 de marzo, primero en la Casa AMEG y después en el Instituto Nacional de Cancerología. La trilogía AMG, AMEG y AMH es el 5 y 6 de abril, que se llevará a cabo en Hermosillo, Sonora, y la participación de nuestra asociación será en el taller de endoscopía. El título es Manejo endoscópico de la hemorragia digestiva y el cupo es limitado y los esperamos, por favor. Y el 11 y 12 de julio en el Hotel Holiday Inn Coyoacán serán los ecos endoscópicos internacionales. Y también ya tiene un valor de 15 puntos por el Consejo Mexicano de Gastroenterología. Y los invitamos a que hagan su pago correspondiente a todos los socios a la cuota anual de 2018-2019, que tiene un costo de 3,000 pesos, y entonces para que tengan esta promoción lo deben hacer antes del 15 de marzo. Y los invitamos a seguir nuestro programa de sesiones en línea. La próxima sesión es el día 11 de abril, con el título de Inteligencia Artificial en Endoscopía, y en nuestro profesor invitado, como ya dijo el doctor Guido, es el doctor Enrique Pérez Cuadrado Robles. Y finalmente les agradecemos su presencia virtual a 270 asistentes de Nicaragua, Perú, Colombia y Ecuador. Y le dejo el mensaje final a nuestro presidente, el doctor Reyes.
Muchas gracias, doctora Zamorano, muchas gracias, doctor Guido. Y pues no me queda más que agradecerles a toda nuestra audiencia esta su participación, su interés en las sesiones. Con esta ya llevamos 4 sesiones de las 8 que tenemos programadas durante esta administración. Recuerden que estas sesiones ya tienen un puntaje del Consejo Mexicano de Gastroenterología. Lo único que se requiere es, cuando menos, ver 7 de ellas, hacer el examen previo y hacer el examen después de la presentación. Pero estas sesiones quedan disponibles para que todos las vean. Ya están las 3 primeras subidas en nuestra página y esta última pronto estará disponible. Así es que los invitamos a que, si por alguna razón no pudieron verla en vivo, la revisen, hagan el examen y puedan completar los requisitos para que obtengan la puntuación del consejo. Muchas gracias, muy buenas noches y que pasen feliz semana. Y nos vemos el próximo mes.